Welcome back to Creating Dementia Solutions. I'm Richard Pyatt. This is a Miles for Memories program on Access Vision and a podcast as well. So if you're active on Facebook, type in the search bar Miles for Memories and follow them so that you're able to see when these come available, these episodes come available. In fact, a few episodes ago, we talked with researcher Dr. Graham Atkin from Michigan State University about the idea that sometimes one can presume that a behavior that someone is displaying is dementia, and actually it may not be, and we alluded to that a bit. Today, we're going to look into that a little bit further and talk with Sherry Sherbin at Miles for Memories about some of the other things that it could be and some ways to think about how to approach that. Hi, Sherry.
Hi, Richard. It's good to see you.
It's good to see you. Thank you for this opportunity. This is really interesting, and I think you'll find it useful how Miles for Memories actually helps folks think through these early stages when you might suspect dementia, but it could be something else. And let's just talk about that, Sherry, for a second. Clearly this happens, right? Because you have a whole a way you approach discussing this. Mm-hmm. So you've seen this before, I presume, where folks jump to that dementia conclusion right away.
They do. You know, I've seen it not only amongst peers and their families, but I've seen it in my own family right at home. And, you know, sometimes the conditions that we experience could be because of an illness. It could be because of an infection. It could be because too many drugs are mixed together, and you take some of those things and happen to have those all at the same time. And bazinga, it seems like the conclusion is predestined and predetermined. And when you start to peel away the layers of what somebody is experiencing, you can start to treat them and rule them out, and treat them and rule them out. And one of the things I find to be most interesting is that some of those things that we look at, that we begin to blame for the dementia behaviors, if we don't care for them and make those corrections, they can also become a risk factor in developing dementia along the way.
Oh my. Well, that's a whole other focus to take, isn't it?
It is.
Yeah. What have you seen happen when someone has jumped to the dementia conclusion? Have you actually seen, for example, a situation in which someone says, oh, this is dementia, and it's diabetes or something else? Mm-hmm. Yeah. What happens?
So family members start to prepare. They start to look at what's going to happen with grandma's stuff and who's going to do what and who takes on what role. And, you know, you start making their way through their visit at the hospital thinking this is the end of ends, right? And slowly, as they start to get their treatment, well, suddenly they're no longer unable to respond to me. And then eventually their conversation is starting to make sense again. And then over here, we recognize that, you know, she's had the wrong prescription all along, and we now transition into one that is appropriate to her. And we walk home with a completely different person who we had not only decided dementia was the outcome, but completely rewrote all of her documents.
Oh my gosh.
And you just kind of go, well, how about that? We didn't need to do that at all.
Right. Talk about jumping to conclusions.
Right. Yeah. Family members look at very certain things, and if there's been dementia in the family, right, any of the different types of dementia, it's really easy to make that jump to, oh, here we go again.
Yeah, my dad likes to say, don't assume, you know, spell that word. And I think that's what's happened here. Yeah. There's a lot of assumptions that happen. So this happens often enough that when you're talking to folks from a Miles for Memories perspective, you've developed a program, a system to help people think through before they jump to those dementia conclusions. Yes. This is really interesting. How do you do it?
Well, you know, we work with this wonderful word called dementias. You know, I have to give credit to Pat Slayton from Home Care Transitions. We got it from Pat, and we've expanded on it since then, just based on our experiences out there in the real world. And, you know, one of the other side situations that might occur, you know, I talked about going all the way to new documents and the like. But the other thing that families sometimes do is just plain ignore it. It's like, this is normal. We don't need to think about it. Let's don't think about it. We already know what's going to happen. We're not worried about it.
Typical aging.
Yeah. And ignoring it doesn't make it any better either. Right? So, we want to stop that from happening. All right, so the letter D comes first in the word dementias, and there's a whole lot of different things in the letter D in terms of what we can rule out and where we might want to go with that. The first one happens to be drugs, and I think, Dr. Atkin talked a little bit about medications in the past and what that might mean. But it's not just a medication with a medication. Sometimes it's a medication with a condition. And when those interact in the wrong way at the wrong time, you get a behavior that in your mind you say, okay, this is it. We're heading down that road of dementia all over again. And you take that path instead of going, why is this happening? Let's go to the doctor. Let's go figure it out. Start with your family physician and just begin to rule things out. And I think the other part of the problem is that folks want an answer today. And that doesn't really happen. If you're going through the process of ruling out other conditions that could cause the behavior, this might take several visits. It might not be today that you walk in and that you walk back out and they go, he's got vascular dementia, and that's just what it is. And so, patience with that, I think, is really important. And so when I start talking about drugs as an example, we have a very significant situation with aging adults and the number of medications that they take. So statistically speaking, they're taking about 4 medications a day for an adult over the ages of 65.
That's the average.
Yeah. When you start getting a little bit older, then they're taking more medications a day. And other care providers expect that. So when I sit at my dentist's office and they ask me for the list of medications that I'm taking and I say none, they're like, what? I don't believe you.
Well, as you say, it's not common. I had a 90-year-old grandmother who was on no medication. They didn't believe her either.
Yeah, right? You forgot. You've
Right.
obviously forgotten about what's going on here. And so, when we can start talking about health as an independence kind of a scenario, that is supported in a variety of other researchers' work, right? And knowing that we have as much as a 30 to 40% chance of reducing our risk of developing any of these different types of dementia just because of lifestyle programs. Yeah. So, all right, so D is the first one, and we kind of go down that route. Polypharmacy is one of those conditions, taking a lot of medications in a day. And, it is estimated that 1 million people who are on a medication are misusing it.
1 million?
Mm-hmm. Yeah. Oh, that 5 million are getting treatment in some way, shape, or form. And aging also increases the risk of the way we might respond to medications. So we don't respond at the same way as, just think about anything that you do, right? Alcohol. You don't respond to alcohol in the same way at 65 as you did when you were 18. No, 21, folks, 21. Or do you understand what?
Yes, I understand that firsthand.
Oh, yes.
Yeah.
So, some of those things that we might experience that someone would automatically go, is dementia a concern? But these polypharma situations can lead us to tiredness, sleepiness, decreased alertness, constipation, diarrhea, incontinence, loss of appetite, confusion on a continuous level.
Sure.
Depression, lack of interest, falls, trips, anxiety, irritability, dizziness, many of which someone might say, is this because of a developing dementia that we don't know about? Not often do we first go to, gosh, could that be a drug?
Yeah.
Right?
And that's just drugs. So as Sherry was saying, we're using each letter of the word dementias to articulate what some of these causes might be. There are other Ds that aren't even past the first letter yet, besides drugs.
A significant one is diabetes. And if we think about what is going on with diabetes and that lack of balance of sugars to the brain and what's happening there, it's already automatically impacting the brain in some way, shape, or form. right? So, we get to a person who's now having a diabetic emergency, and if you've never seen that happen, you might, as you look at that person, go, okay, they're not responding to me. They are feeling and or looking faint. They have a sense of drowsiness and confusion, and just from the diabetic emergency that's happening because maybe they're not managing their diabetes in the way that they should, right? Or maybe they didn't quite eat the way they should have before they decided to go run around the block, whatever the case might be. So diabetes is pretty significant, and it is it should also be an alert and a warning sign that there are other things that we need to take care of to reduce our risk for going in this direction later on.
All right.
So that's the next D.
Right.
Right.
And a couple of others too.
Right. So delirium is next. Sometimes we throw delirium in there thinking that it's the same thing. And delirium is a little bit different. It is really one of the contributing factors is a severe chronic illness of some kind. And it is a change in a metabolic balance that's going on in the brain, possibly from infection, possibly from surgery. It could also happen from drugs, alcohol, interacting or withdrawal from drugs or alcohol as part of that process. And so we see those same symptoms: confusion, disorientation, memory loss, slurred speech, difficulty speaking coherently, hallucinations, changes in sleep pattern, and changes in mood or personality. And if someone is older and we start going through these based on some of those situations that they've come across, again, it's really easy to go, yeah, she's just getting older, he's getting older, we're going to be fine, let's just make our way through it, it'll be all right. It's just natural, we've been through this before. Sure. But in reality, if this is new for them, then it's something that needs to be evaluated. It's not something that started this morning, right? What has led to that this morning, right? And that doesn't mean with certain types of dementias, when we start talking about vascular dementias being very incident related, so might be related to a stroke as an example, so that is in the moment. Either way, they need to have that looked at,
Yeah.
right? So, we
That's
need to make that step and start going in that particular direction. The last one I want to throw in there, because this happens a lot, is dehydration.
Well, you would think that some of these symptoms, again, are similar, right?
Yeah.
Yeah.
So, even in today's society, we have a tendency to not quite drink as much as we should in terms of water, in terms of hydrating our system. And then we throw into the mix different medications, maybe that has been added to the mix that is impacting our level of fluid control. And so it can be misunderstood if we don't get enough fluids in our system. And that's an easy one. It happens whether we're 12 or 19 or 95. So look at what's causing that immediacy, especially with the additions of medications. That could very well be one of those problems.
Right. Whew, finally, we're moving on to the letter E. There could be an emotional component to what's happening with a person.
So when we start talking about emotional components, depression is one of those that jumps up to the top of the list. And as we age, there's a lot more opportunities for loss, right? It's not that we don't lose somebody when we're 18, but our friends when we're 95 tend to be more likely to be those that we are losing on a regular basis. And so, there's situational depression, and I'm not a clinician, so please make sure that folks know that I am not a clinician. I play one on TV. It's true. But it's really important. And if somebody's experiencing those things, it would be a time for someone, again, to seek additional medical care or attention to find out what the causes of that behavior happen to be, right? Is it normal for them? We have people in our lives, I dare say that you probably do, I know I do, but we have the optimist and the pessimist. There's a difference between pessimism and depression, though.
That's true.
And the way that we look at the world.
Okay.
So that kind of wraps up that first D, because there's another one coming along.
Well, right. We went to E, emotional, but it came back to D, depression. So
Yeah.
Now, can we get to the M's?
Let's go, M's.
All right.
Yeah. So when we talk about metabolic, which is really the M in this particular case, really anything that we're looking at as far as the metabolism is concerned is something that with care can very easily be treated.
Seemingly
right?
so.
Yeah, and to move some of those things around. One of those other things that lands in the M's is malnutrition. And malnutrition can have also a metabolic impact on an individual. But when we look at those things, if I just throw out the list of a metabolic impact, we have fatigue, lack of energy, easily tiring, muscle aches, tenderness, stiffness, muscle weakness, trouble walking, pain, stiffness, swelling in the joints, depression, impaired memory, nausea, and irritability.
Boy, we're only to the M's, and you can see how intricate this has become.
Yeah. So, it is one of those things to rule out and to look at with significance. One of the other things that I do is the Be Seen on Air show. And recently we had Devon on talking about the value of the food that we eat or the food that we don't eat.
Right.
And fresh foods versus really processed foods. And in some cases, for someone's nutrition and ability to eat something, we have to process those pretty significantly. But the beginning source is an important part in everything that we might do. And, we want to be able to make our metabolism work and our metabolic system function at its highest capacity. And both of those impact that.
Makes a lot of sense. DEME. We're back to the E's now.
So these two E's are more sensory in nature, and it's about how we live and perceive the world. So the first one is eyes, and a sight loss can happen because of an injury, obviously. A sight loss can be something that happens and develops over time. Let's look at cataracts as an example.
Sure.
A sight loss, you can look at it and just imagine you're the person who's now is losing your sight, or it's becoming more difficult for you to see. You might withdraw. You might not want to go out and be with people. You might not want to spend time with others, which means you become more isolated and alone. And if we don't do something about it, they will continue to stay in that environment. And the more isolated that they are, the more lack of interaction with others, the more we increase our risk for developing dementia.
I think the same would happen with hearing loss too, right?
right.
I call to mind a great uncle of mine who was nearly completely deaf, had a little bit of hearing in one ear, but this happened later in his life. So he did become more isolated. Yeah. And we would have family gatherings and he would have to sit back and just sort of observe because he really wasn't hearing what was being said. So it became difficult. It became a situation in which he didn't look forward to those occasions.
Yeah.
And so you can see how that could progress into a situation where someone might say, is that dementia?
Yeah.
What is that?
And as you take the ears and the hearing loss into consideration, our brain is working so hard to try to manage the information surrounding you that it's not paying attention to other things. And it will use every cue that it can, right? So as you speak, maybe they're watching your face, which was really hard when folks were wearing masks. Right?
Oh, of course.
And being able to interpret what was going on in their world, making it easier to remain isolated and withdrawn and seem somewhat depressed. Impacting memory because they're not engaged in those things. It's kind of like a topic. You talk about a topic all the time and stop talking about it, and your focus goes over here, and you kind of forget some of the details over here because you've been focusing on this.
Sure.
And so again, it makes it appear as if it's a memory loss situation when it's just really not been part of your daily activity anymore. Jeopardy is, right?
Yeah, right.
So those hearing aids for your grandmother are really important, not only to continue to help them be engaged in conversation, to be engaged socially, to be able to hear and process, but also to either slow down the progression of a dementia that might already be there, but also to reduce their risk for it.
Yeah, that's very interesting. Sherry Sherman is here. We're talking about using the word dementias, plural, to articulate what other ailments a person might be facing that aren't dementia. So now we're on to N.
Yeah. So this is one that folks may not go to very quickly. So we're looking at normal pressures within the brain, right?
Normal pressures, physical pressures.
So hydrocephalus would be one of those, and as a result of that, what we're looking for is a buildup of fluid in the cavities in the brain. So it's applying pressures, making it really uncomfortable for starters, right? But it's going to impact memory. And we want to release those pressures. It's going to impact our ability to process and reason. It will also impact our coordination and balance, maybe making it more difficult for you to walk, increasing a risk for falls and trips and that sort of thing. And you may be experiencing ataxia, which is really without coordination, so a loss of muscle control, as an example. And you start throwing all these things in there, and it can impact your fingers and your hands and your arms and your speech and your eye movement, all of which might make someone go,
Yeah.
this could be the thing, and we're going to have to look at how we provide care for it. But if we can evaluate that and find out that we have a pressure issue, maybe there's a lot of reasons why that pressure might be there. So we want to try to eliminate that, reduce that, and care for that. And gosh,
Yeah.
brand new person standing in front of you. It doesn't happen overnight, so people need to realize that, addressing any of these issues, we may not necessarily fix them overnight, but at least we're able to identify them and move on. I mean, I just got an eye exam. My new glasses don't get here for another week and a half.
So you continue to use what you got.
Right. I just, yeah. So, it can be a challenge. We just have to be a little bit patient.
Mm-hmm.
But when you get a diagnosis that's different and you have an actionable step, it changes the direction that you're on, at least in the immediacy.
Right. And I was going to say this at the end of all of this, but imagine if you never do figure out what's happening and it's one of these other things and you don't have that diagnosis.
Yeah.
You don't ever get that addressed.
No.
Yeah. All right, the letter T.
Okay, so T is tumor. It's obviously different where that tumor is located. In this particular case, I'm looking at brain tumors, which in essence, in some cases, are going to start to now impact memory. It may lead to memory loss. It may lead to difficulty with new memories, depending on where the tumor itself is located. And, we want to look at signs of severe memory loss when this starts to happen. We want to blame it on dementia. And in this case, maybe you would rather it be dementia than a tumor that, you can't do anything about. But when those cognitive functions are impacted, that might be one of those things they're going to need to rule out as well.
All right, I.
Okay, so I is interesting, and if you have a loved one that has ever been in your care for a period of time, even yourself, you might begin to notice this, but infections is one of those things. And so our body is trying to process things differently. So its whole goal is to set our immune system up such that it's trying to figure out what's going on wrong. So we have marching orders to fix that and deal with that and try to get our immune system back in balance and our whole body back in a homeostasis kind of a scenario. And so, it may impact our ability to reason right. We may experiencing maybe thinking of stroke. We may be thinking, if we get into infections, maybe it's meningitis. Different headaches would be a symptom that you might experience from that. But hearing loss, visual problems, blindness potentially, and even a loss of pain or temperature sensation could all be different kinds of things that we would experience because of where an infection might be. So, and those dementia-like symptoms that we've talked about on this podcast over and over again would be one of those things, could be one of those things that would surface as a result of that. UTI is very common in older adults. So if someone is starting to behave a little unusual, that might be the first thing that they're going to go for. Let's go check and find out if there's an infection.
Wow.
Yeah.
All right, another I would be an injury.
Yes. So depending on where that injury happens to be, a head injury obviously would be the most problematic. We look at the different kinds of head injuries as we go forward, and traumatic brain injuries, and we'll talk more about that in a little bit. But all of those types of injuries that may impact the way in which our nerves function and tell our body to do different things. So it's not just the brain itself. It could be anything along the spinal column is out of order and is not reacting or responding. That would cause us to potentially think that there's a bigger problem than there is. I mean, an injury to the brain in general or head, a concussion is a problem, but we can work through those things.
Sure. Wow.
Yeah.
A. We're getting there.
We are A. So one of the things that jumps up is alcoholism in the aging population. We don't look at our aging adults as those individuals that have an alcohol issue, right? We just don't look at that way. And the reality is that drinking slows reaction time. There's no ifs, ands, or buts about that. And it will impact our coordination. It interferes with eye movement, which will also interfere with the information processing that's going on, right? And happening. So they're at an increase of traffic accidents, as an example, and we don't want them driving when they're drinking alcohol. And we don't want them wondering whether turning here or not turning here because the bank is not on the corner anymore, right? Mm-hmm. So we lose that understanding of certain things when we're under the influence of a substance. Let's just put it that way. Yeah. Even though we may feel as if it is self-medicating in some way, shape, or form for us. And so it can also lead to that area of forgetfulness that we now begin to associate with dementia, that sense of confusion, and those symptoms all taken together can be misunderstood as Alzheimer's disease.
Wow. And the last one, S, sleep apnea.
Yeah. Who would have thought, right?
Right.
So when you look at what's going on in the brain, our body does a lot of healing during our sleep. And if a person who is sleeping is constantly having that sleep interrupted because they've stopped breathing, we want them to wake up, obviously, so that we can reset that and continue to move forward. But, if you've had an evening where you didn't get sleep, you didn't sleep well, you may wake up with difficulty that next day in terms of what you're doing, ordering your day, and even driving, depending on how much sleep you didn't get, right? Being that person who is falling asleep at the wheel, that can be a really big problem as you get ready to go forward. And so one of the things that they have looked at for a long time is that connection between sleep apnea and Alzheimer's disease. And is there a connection? Well, repeated studies time and time again now are making that connection for sure. Instead of, looking at it from a surface area level saying this really can impact it, but does it? Is it situational? How does that go? And there are a variety of studies now that are making that connection and are offering a treatment. So, if we have the CPAP machines and a variety of other sleep treatments that we can get throughout the evening that will not only prevent us from waking regularly, but making sure that our body is perfused with oxygen the way it's supposed to be, which includes the brain. So we want our brain to get all that oxygen it needs in order to thrive.
Absolutely. Well, there you are. DEMENTIAS. All of these things that could potentially be causing a behavior that someone might interpret as dementia, and it may not be. I suppose the bottom line, Sherry, here is we have a lot to sort through before we can make a diagnosis of dementia.
Right.
And we really need a medical professional to help us get through all of it.
Yes. We have been very fortunate with Miles for Memories to have medical researchers that have been engaged in helping us develop things along the way. Whether it's a product or it's research that we do offer, they're there to help folks make that step. You know, let's say you ruled all these things out and you're still having those challenges. Well, it really could be dementia. Right? And then you want to make those next steps. And you know, you can make those steps, at least initially, from home. There are some tests that you can take from home, some evaluations that you can do from home, and then take those results with you to the doctor's office.
Sure.
The doctor can look at those and then offer additional testing to really kind of continue to make a more targeted diagnosis. You know, dementia in general is not enough.
And you can do some of these screenings at home. In fact, your dementia informational booklet that's available in a number of locations around Calhoun County and also on the Miles for Memories website can help walk you through some of those.
Yeah, for sure.
So start there on the Miles for Memories website. Look for that. It's right on the front, as I recall. So you can download it right there from the homepage on the Miles for Memories website and have a look at that. Sherry Sherbin, thank you. This has been really enlightening.
Thank you. I appreciate it.
Creating Dementia Solutions right here on Access Vision and a podcast as well. Check the show notes. Click through to the Miles for Memories website for this and more information, and like us on Facebook as well. I'm Richard Pyatt. Thanks for being with us.